Welcome and good morning, everyone. We have an amazing event put on for you today. This is the state of LGBTQ nurses and healthcare. We couldn't be more thankful to do this partner event with the National Coalition for LGBTQ Health. We're going to have some amazing speakers today, including Scott Bertani, Sarah Broat, Jackson Fuller, and Benjamin Hughes. We're also going to be having our ANA California Advocacy Institute fellows who are working on ANA California's LGBTQIA plus equity in nursing campaign, Dr. Bree DeBose and Misty Mandeville here today. Such a amazing event and very timely. We're going to describe findings from both ANA California and the National Coalition's individual surveys and assessments, and showing you some alignment perhaps between some of the state and national data that we're seeing. We're going to examine some of these implications and findings so we can work towards advancing health equity within nursing and the broader healthcare team, and as well as identify opportunities for you all to advocate and strengthen inclusive practices and support. Um, this is such an important webinar and discussion here today. There have been significant federal policy reversals and executive actions that have targeted gender identity recognition, data collection, access to care, you name it. There have also been several state level legislative efforts with over 850 anti-LGBTQ bills that have been introduced within the past year. So, with this combined effect, it couldn't be more timely to have this partner event, share the data, talk about the barriers, talk about the upcoming challenges, and really dive into the purpose here. Now, I wanted to leave this last piece here for all the nurses that are tuning in today. ANA's Code of Ethics has been updated to include a lot of powerful language centered around equity. Provisions 1, 8, and 9 all talk about reasons why that we should have compassion and respect, protect human rights and health disparities, and ensure that we can articulate nurses' value that maintains that integrity and principles of social justice into all of our roles. So, this is a big, huge thank you to all those that are tuning in. Thank you for being here, for being allies and advocates. And thank you again to our partner over here at the National Coalition for LGBTQ Health. I'm going to get off my soapbox today, but if you want to learn more about our presenters, I'm going to drop the event link here in the chat. So that way you can look into their bios and learn a bit more about themselves. The final note for today is those nurses that are tuning in, ANA California is offering 2 continuing education hour credits, and an email will be sent at the end of today's event so you can complete your CE certificate evaluation form. And with that, I would like to pass it off to Scott and the rest of the team here. Thank you so much for being here.
Hey, thank you very much, Jared. And I just want to echo exactly what you just said, and to thank the American Nurses Associations of California and together with the National Coalition for LGBTQ Health in this really important conversation. So with that, greetings from the National Coalition, and good morning, good afternoon, good evening, or just plain old good day to you all. And like Jared said, I'm Scott Bertani, leading advocacy efforts for the National Coalition for LGBTQ Health. And today, my role is to help set the stage, to frame the landscape behind our third annual State of LGBTQ Health survey. And as you listen, we want you to think about how you can use these findings in your own work to help inform action and strengthen systems and support the nurses, providers, and workforce delivering LGBTQ plus care. And after me, my colleagues will unpack what the data mean for advocacy and education and health equity. And just as the American Nurses Association of California's assessment explores comfort, confidence, and culture within nursing practice, our survey looks at those same questions through a systems lens, how policy and infrastructure and trust synchronize to shape the care environment providers work in every day. And together, I think they paint a picture of where inclusion meets implementation. Next slide. And as Jared said, here are our presenters, myself, Sarah, Jackson, and Ben. Next slide. And as background, so the National Coalition for LGBTQ Health, we were founded in 2000, and our work is to improve the health and well-being of LGBTQ plus communities. And we do that through data and research and advocacy and health literacy. And we work to equip providers to create affirming spaces where informed and consensual care and open communication can promote health spans across lifespans. Next slide. And now entering its 24th year, National LGBTQ Health Awareness Week, it remains a rallying cry for action, and it helps bring together providers and advocates and community leaders to confront systemic barriers to care. Next slide. And, each year, the third full week in March, it works to amplify key conversations and highlights the organizations and providers and community who are advancing LGBTQ plus health equity amid shifting policies and funding. Next stage. Okay, so let's set that stage, because I think this slide really captures the paradox at the heart of LGBTQ healthcare right now. And with that, national polling from Gallup and KFF in 2023, it shows that 7.6% of US adults now identify as LGBTQ+. It means the US had entered a demographic and cultural turning point. In barely a decade, the number of adults who openly identify as LGBTQ has turned from the margins of 3.5% into measurable and mainstream visibility, or roughly 1 in every 14 adults. And that's not just societal change, it's structural. It signals a generation of people raised amid greater openness who, up until that point in 2023, could age into full civic and political and healthcare participation. And that's where real progress, at least on paper, but in practice, today's new normal, we see a widening fault lines between identity and access. In fact, according to our own State of LGBTQ Health National Survey, nearly 1 in 3 LGBT patients avoid care because they expect discrimination. Two-thirds of providers also report greater fear and mistrust among patients, and more than half have already reduced their own visibility to avoid backlash. So the data, it makes it plain. People may be more visible on paper, but they feel less safe in practice. And that tension between being seen and being protected is exactly where today's discussion begins. Next slide. A hard slide. So, since January 20th of this year, the policy environment for LGBTQ plus health has shifted fast and hard. And what we're looking at here is the broader federal backdrop. Those are the operational shocks that have defined this year's LGBTQ plus health landscape. So, in this landscape, new executive orders and agency actions have redefined how sex and biological sex are interpreted in federal law. Section 1557, non-discriminations protections, they've been narrowed. Marketplace, essential health benefits, reviews are quietly reassessing coverage for gender-affirming care and reproductive services. Federal agencies have also been directed to scrub existing rules, training materials, and data systems of terms related to gender identity, sexual orientation, and DEIA plus B. And within this environment, the Centers for Medicare and Medicaid Services, or CMS, in April 2025 sent a letter to state Medicaid directors on gender-affirming care that only deepened the concern that federal policy is being used to restrict rather than support evidence-based care. Meanwhile, the ongoing shutdown has intensified fiscal strain, with proposed cuts to Medicaid and reductions to the Patient Protection and Affordable Care Act premium tax credit subsidies that threaten to destabilize coverage for millions. And that's especially for low-income LGBTQ plus individuals and people with HIV. Medicaid disenrollment too also destabilizes something called Title 19 providers who offer targeted case management as a key tool for treatment adherence and care coordination and addressing social drivers like housing and nutrition for people on Medicaid. And the proposed elimination of CDC's Ending the HIV Epidemic initiative and sweeping cuts to HIV prevention programs, well, they signal a stark retrenchment in federal strategy. The Health Resources and Service Administration, or HRSA, which supports primary care access and administers the Ryan White HIV and AIDS program, has also seen its funding capacity strained, and with direct effects on HIV care delivery and LGBTQ plus health initiatives. Funding for community centers is also affected as well through HRSA's Bureau of Primary Health Care, and that remains short-term and uncertain. And when the continuing resolution expired on September 30th, the program entered a temporary funding gap, and that halts new grant awards and renewals until appropriations resume. And existing Section 330 grants, Ts, they can draw down prior year funds, but new awards and service area competition renewals have paused until appropriations resume. Advocates note the mismatch, right? There's more patients, there's higher need, but CR level dollars and periodic freezes, they keep clinics open only month to month, and that forces attrition and project deferrals for LGBTQ affirming services that are integrated with HIV care and behavioral health. And unions and health employers describe expanded layoff plans amid the ongoing federal shutdown and the more than $1 trillion in proposed cuts to Medicaid, Medicare, and the Affordable Care Act. And even if funds, or positions are even reinstated, the stop-start cycles erodes capacity and delays guidance, grant making, and oversight, and that directly affects LGBTQ plus health programs that depend on those systems for stability and reach. Oh my gosh, the regulatory temperature too has shifted as well. The Food and Drug Administration, they've tightened review timelines amid staff turnover and political pressure. And in the third quarter, note this, its drug approval rating dropped to 73%, down from an average of 87% over the previous 6 quarters, while rejected applications rose to 15% and reviews daily nearly tripled. So, too, leadership turnover at the Center for Biologics Evaluation and Research, or CBER, the firings and subsequent restructuring of the Advisory Committee on Immunization Practices, and credible plans to make the U.S. Preventative Services Task Force also show how once apolitical scientific bodies are now under political review. So too, the Biomedical Advanced Research and Development Authority, or BARDA, that's housed within HHS's Administration for Strategic Preparedness and Response that oversee vaccine procurement and stockpiling. That was once a model of rapid community-informed action during the Mpox break, but today its process has grown more cautious. And that slow readiness and vaccine preparedness, important for LGBTQ plus and immunocompromised networks, is really curtailing the capacity for future outbreaks. And one need no look further than the recent Clade 1 Mpox case in Long Beach, right? And that underscores why community-based readiness and trusted provider networks, that they still matter, not just for containment, but for confidence. And for nurses especially, this moment reaffirms their role as the system's steady hands. They recognize patterns, they sustain outreach, and they keep patients connected even when the invisibility itself, it carries risk. So, yet in some spaces, innovation kind of continues. In June, the FDA approved a twice yearly injectable for HIV prevention, showing that while progress in safety and access is still possible, even amid some of these headwinds, but it shows that progress probably now unfolds under closer scrutiny and within a shrinking space of public trust. And in states like California, those federal constraints ripple through at the program level. And conversations have even raised the issue that the state may soon rely on its AIDS drug assistance program under the Ryan White rebate fund to sustain services if certain parts of the Ryan White program are cut. And I think that's an early warning for how state reserves are becoming the backstop for national retrenchment. Next slide. So the perception of constant strain and siege has only grown amid leadership changes at the National Institutes of Health, NIH, and its National Institute of Allergy and Infectious Disease, or NIAID. And that's following the removal of Dr. Janine Morazzo and several senior officials. And importantly, the cancellations of future HIV vaccine consortia funding. The same applies to the gutting of the CDC and the proposed folding of agencies into a newly formed Administration for a Healthy America, which would consolidate multiple existing health agencies, including HRSA, the Substance Abuse and Mental Health Services Administration, or SAMHSA, and parts of the CDC into one unified body. And at the same time, the CDC's Emergency Epidemic Investigation, or EEI, renewal, it's open for public comment right now, and a procedural review that would normally pass quietly, but it now underscores how outbreak authority and LGBTQ data access have become politically charged. Likewise, the comment period for the National HIV Surveillance System, or NHSS, it carries far greater weight. And since January, the CDC has removed dozens of web pages and data sets on HIV, LGBTQ plus health, youth risk behaviors, and STIs to comply with new federal language directives, taking down materials from the Youth Risk Behavior Surveillance System, and that's a key provider portal. And the HIV Prevention Action Coalition, which is a work group of the Federal AIDS Policy Partnership, formally alerted the CDC leadership to the removals in October, and it cited the loss of 22-page prevention-related pages that are amid, record congenital syphilis rates. And after public and legal pressure, a court ordered partial restoration. But that rollback, it reflects a broader trend of scaling back SOGI and HIV data, and that limits efforts to track disparities and target resources. The chill extends to the federal HIV clinical practice guidelines. The NIH Office of AIDS Research has initiated a sustainability review, and current panel support is expected to end by June 2026 unless renewed or restructured. These treatment guidelines, they link evidence, reimbursement, and quality of care, and without them, updates, they risk fragmenting and widening inequities. Inequities, which is another word that was embargoed by the current administration. So all in all, when guidance and funding and data constrict at once, care itself tightens, and where every layer, whether it's from managed care formularies to frontline nurse staffing, we all feel the strain. And California's rural systems, they show this in real time. Programs like the Healthy Rural California, which aim to expand the workforce where shortages are most acute, but Medicaid cuts and reduced federal supports, they threaten rural hospitals, tribal clinics, and residency pipelines. In fact, UC Davis leaders described a more dire cycle, fewer residencies, shuttered critical access hospitals, and graduate medical education slots that are tied to shrinking revenues are harder to go on. And when Medi-Cal revenues drop, Proposition 35 funds for rural training collapse too. And that leaves regions like, Chico and Redding and the North State even further from equitable access. So whether this new rural health transformation can backfill those losses, that kind of remains uncertain. The program was designed to modernize rural care delivery, but its success, well, it hinges on whether CMS and states treat HIV, syndemic conditions, and LGBTQ plus health as central, not secondary to those reforms. And California's Proposition 1, well, it adds another dimension. While the Rural Health Transformation Project is meant to focus on Medicaid delivery and workforce design, Prop 1, it reshapes behavioral health and housing infrastructure. And I think together they contest whether states can align health, housing, and behavioral care systems under one equitable framework. So what's left from all this is a health system that really feels pull between politics and practice, and where science and guidance we no longer trust and they don't necessarily align. So, federal uncertainty, it reaches state systems and daily care, and it turns what was once neutral public health into contested terrain. And those in the middle, LGBTQ people, people with HIV, and the providers who serve them, we feel that strain first. Next slide. So, zooming out, these threads mirror what our third annual State of LGBTQ Health Survey captured. It's a system destabilized. Its fear and stigma, they now drive both patient behavior and provider decision making. Visibility is rising, but trust and safety, well, they're collapsing. And what providers describe, it isn't a momentary disruption. It's a fragile system that's fading from view. And just as LGBTQ health needs grow sharper and more urgent, California nurses, you work in one of the most supportive states in the country, and you're often cited as a model for LGBTQ inclusive policy and care. But federal shifts still surface in your daily practice, and that reveals the limits of state protections. Medi-Cal, Title 22, and non-discrimination laws have built one of the strongest frameworks in the nation that's reinforced by the Board of Registered Nursing's requirements for cultural humility and LGBTQ plus competency in education. But federal systems still set the floor for reimbursement, data visibility, and research guidance. So changes to Medicare and Medicaid billing, HRSA oversight, a 340B pilot program, and even CDC reporting reach California's safety net clinics just as they do elsewhere. State programs can cushion the impact, but they can't necessarily block it entirely. So while California offers structural refuge, it isn't a shield. Federal retrenchment still filters through, and it's pressing on access and workforce stability and clinical confidence. And that strain shows up in the data, right? Medicaid payments rarely cover the cost of care, or 340B changes that threaten budgets, and staffing gaps that continue to widen. But meanwhile, fewer than 6% of Medi-Cal members have responded to optional SOGI SC questions. And that shortfall isn't just technical, it reflects how data systems and intake processes and cycle times can make disclosure feel either risky or unnecessary to some people. And when fear, stigma, and policy pressures make self-identification feel unsafe, the data stops before it even starts, and outcomes will fail. Those missing data points, they hide the disparities nurses see every day. And embracing your role as advocates, shaping environments that counter fear and stigma, and aligning care practices with broader public health protections is why your work matters most. So with that, I'll turn it over to Sarah, the Coalition's Associate Director for Health Services Research and Evaluation, to walk us through what we've been all living and the data, both qualitative and quantitative, that'll prove it. Sarah, you've got the comms.
Thanks, Scott. So I'm going to start off. I'm going to hand it over to my research manager, Jackson, to set the stage a bit with our methodology and background, and talk a little bit about those who participated in our third annual national survey this year. And then I will jump into some of our findings and implications. Next slide.
Awesome. Thanks, Sarah. And thank you, Scott, for helping to set the landscape a bit here. So we'll be diving in now a little bit more to some of the findings and implications from our national survey of healthcare professionals who serve LGBTQ communities. And this survey was intended to assess the current state of LGBTQ health in the US, some of the barriers and facilitators in providing and accessing LGBTQ health, the workforce experiences of healthcare professionals within that LGBTQ health space, including their burnout and training needs, and the impact of policy changes, particularly related to that gender-affirming care and anti-LGBTQ legislation. And we'll be particularly noting also the perspectives from the nurses responding to the survey on the barriers and opportunities for improving care for LGBTQ individuals. Next slide. And so, Uh, a little bit about the background of our survey. So this survey was again targeted towards healthcare professionals who are providing services to LGBTQ individuals. And so this included clinical and non-clinical staffs from hospitals, community clinics, public health agencies, HIV service organizations, and advocacy groups. And our sampling method for this survey, participants were recruited through LGBTQ health networks, professional organizations, and referrals from peers via emails and social media. And the inclusion criteria for this survey was limited to just healthcare professionals working within the US and engaged in direct patient care, health policy, or health services research related to LGBTQ populations. And throughout our survey, we ended up collecting a total of 567 respondents, with 68 of those being responses from nurses that we'll again discuss throughout the remainder of this presentation. And the survey was administered using REDCap, which is a secure web-based tool for surveys and data collection, where participation was anonymous and voluntary with no personal identifying information collected from respondents. And the survey was set up as a mixed methods approach using closed-ended multiple choice style questions, open-ended free response questions, and some ranking and selection-based questions. And each of these types of questions was analyzed using descriptive statistics, some thematic coding, and cross-tabulations to really investigate the trends and relationships between these variables to understand the true landscape of LGBTQ health in the US today. And we'd also like to note that the survey was fielded in January and February of this year. And so as Scott kind of talked about earlier, the landscape even July, some of the findings and implications we'll discuss later. Next slide. Again, so our survey ended up reaching a large range of respondents from both clinical and non-clinical professionals, especially again the nurses that were reached. And so these nurses included the registered nurses, nurse practitioners, nurse managers, and licensed practical nurses. And this large range of organization types that you can see right here was also reflected within the nurse breakdown of our data, reflecting a wide range of perspectives of both nurses and overall throughout the survey. Next slide. And again, noting the reach of our survey, we had representation from the entire survey from 43 states, DC, and Puerto Rico. And from the specific nurse subset of our population, we had representation from 30 US states, DC, and Puerto Rico. So you'll see a wide range of perspectives, and we'll talk a little bit more about some state-specific policy responses in the survey later. And so now I'll pass it over to Sarah to talk a little bit more about the results.
Thank you, Jackson. Ben, you can move to the next slide. Great. So I'm going to start today by talking about what providers and respondents were asking for from the data. Everything that we saw really built down to one theme, and it stood out very clearly, which was the need for stronger institutional support. Participants in the 2025 State of LGBTQ Health Survey said that improving care for LGBTQ plus people requires more than one-time training sessions. They emphasize the importance of civic, scientific, and historical education for all staff, alongside task-specific training that helps providers deliver affirming and respectful care. We saw a lot of calls for stronger buy-in from leadership and more resources to make inclusive care sustainable. Many respondents wanted to see more LGBTQ identifying providers in leadership and clinical roles to help patients feel seen and supported. We saw almost 60% of responders saying that culturally sensitive and accommodating staff were critical to improving care, while more than half highlighted the importance of LGBTQ-focused training. Several also pointed to the need for dedicated funding and federal support that we are definitely still feeling today. Taken together, these responses show that improving LGBTQ plus health requires a broad approach. We've got to build the workforce, we need to strengthen policy support, and we have to invest in systems that protect and empower providers. We're hoping today that the survey data can help those efforts across the nation, and that we can work together to make that happen. Next slide. Now, looking at the bigger picture, many providers told us that systemic barriers continue to make it harder for both patients and clinicians to access or deliver care. Respondents were citing stigma and discrimination as some of the biggest challenges. Others mentioning of insurance coverage and a general distrust in the healthcare system being a major barrier. State level policies were another common concern. Restrictive laws and uncertain funding are creating confusion and fear in many places, which discourages some providers from offering inclusive services, and for patients to be uncertain about what they're going to be faced with when they enter a medical space. The challenges point to a need for policies that protect LGBTQ plus individuals from discrimination. We need to expand insurance access and help rebuild trust between patients and providers. Even as awareness grows, the healthcare system still struggles to keep inclusion a priority. Next slide. These policy pressures are also taking a major toll on mental health. Nurses specifically are reporting that LGBTQ plus individuals are facing worsening mental health challenges nationwide. Nearly 3 in 10 nurses said that they were concerned about cuts to mental and behavioral health funding this year. More than half, 52% of all respondents said that there is a shortage of behavioral health providers, which has led to incredibly long wait times and even fewer services than we had before. Discrimination, stigma, and lack of culturally competent providers make it even harder for LGBTQ plus people to get help. And many providers said that they're struggling to meet the rising demands with the limited staff and resources that they have. To close these gaps, we need absolutely more investment in behavioral health training, funding, and recruitment of providers who understand the specifics of LGBTQ plus issues and can offer that affirming support. Next slide. And this next slide continues on that same story of the continued mental health demand. Respondents are saying that their clinics often can't keep up with the number of people seeking mental health support. So they're seeing sharp increases in anxiety, depression, and reports of suicidal thoughts. And many are mentioning higher rates of gender dysphoria and substance use. And these challenges just reflect the intense pressure that many LGBTQ folks face, pressures that can feel isolating and overwhelming. And when we combine that with the shortage of qualified providers, we end up with obviously a dangerous gap in care. Next slide. Now I want to turn a little bit to one of the most urgent issues in our findings is access to gender affirming care. Nurses identified the top barriers to providing this care as the federal executive orders, followed by political climate, a lack of training, and challenges related to insurance and local laws. From the patient side, they're saying the most common barriers were distrust in the health system, cost, fear of stigma, afraid of what it would look like that conversation would be when they would tell their medical professional that this is care that they're looking to seek and what that could result for them. The data shows that over 93% of respondents worry that changes to Medicaid and Medicare could further restrict access to gender affirming care, and that this concern stems from a deep frustration with the environment. Even those committed to continuing care said they feel trapped between professional responsibilities and the growing list of federal and state restrictions. Next slide. This slide continues again on that same theme, focusing on the emotional impact. Respondents described a sense of exhaustion and despair as barriers just continue to grow. Even in supportive organizations or in support of states like California, people are worried about whether funding, policies, or even state laws could just change overnight. One respondent said, quote, "It feels like every step forward is met with 2 steps back." This uncertainty creates instability for everybody involved. It adds another layer of stress for healthcare workers who are trying to provide care in an increasingly politicized environment. These stories remind us daily that policy decisions have real world and real human consequences every day. Next slide. This slide shows a visual snapshot of where those policies are taking effect. On the map, the darker purple states show where almost all respondents reported that they are aware of restrictive LGBTQ plus healthcare policies. And these are the states where the policy environment is the most challenging. Next slide. And then almost half of all respondents along the same note said that they were aware of these restrictions, and 83% said that the policies have directly harmed their patients' mental health. when we looked at just the nurses' results, 15% said that they prevented from providing care because of state or federal laws. These policies are disrupting care every day across the country. Clinics are pausing services, patients are delaying treatment, and some providers are questioning whether they can continue in the field. The message here is simple but powerful. Legislation doesn't exist in isolation. It shows up in exam rooms and affects mental health, and it changes the patient-provider relationship. And that's why what we know to be true is advocacy is not optional, it's essential. Next slide. And with all of these growing pressures in mind, it's not surprising that we've seen, reported increases in burnout, and it's become a major issue year over year. Nearly half of all respondents and 44% of nursing respondents said that they have considered leaving their jobs in the past 6 months. More than half of nurses said that this feeling has grown stronger just in the last month, so just in the beginning of this year, and I'm sure that is increasing month over month. Many described feeling emotionally drained several times a week or even every day. They cited burnout, political hostility, and moral distress as the biggest reasons they are thinking about leaving. This shows why workforce retention must be a priority in order to protect the people who deliver care to sustain quality and access for LGBTQ+ patients. Next slide. Even with the challenges, there is hope in what we see in the data and what providers are asking for next: education and training. Something we know at the coalition is important, and we try to provide, as much as possible, as free as possible, and with as many partners as possible. So thank you again for connecting with us so that we can have this presentation today. This is a step forward towards hopefully aiding in that hope. The top topics for nurses include improving access to gender-affirming care, caring for LGBTQ+ youth, and creating welcoming clinical environments. Beyond LGBTQ specific topics, we're seeing providers wanting more training on navigating legal and social barriers to care, caring for undocumented individuals, and understanding programs like Ryan White, 340B, and PrEP. This level of interest shows a workforce that is obviously still eager to learn and improve, even in the face of great political hostility. And continuing this education and being able to offer that education, especially training focused on health equity and cultural competency, can just strengthen providers' confidence and reduce that burnout by equipping them with practical tools to serve their patients better. Next slide. And then despite all of these obstacles, I love including the quotes we get from, our qualitative data here. There's a story of resilience and action. Providers are organizing, they're mentoring, they're supporting each other. Many are getting involved in advocacy networks, community coalitions, like our national coalition, and continuing education programs to protect LGBTQ+ care. Some are even joining legal efforts to challenge harmful policies as subject matter experts, while others are seeking new funding models or flexible scheduling to reduce burnout. These efforts show a determination and creativity in the face of adversity. The data obviously shows strain, but it also shows a resolve to move forward. Providers are not letting fear dictate the kind of care that they deliver, and they're turning data into advocacy and transforming challenges into collective action. So as I wrap up, it's important to remember that these numbers represent real people and real experiences. Nurses and other healthcare professionals remain on the front lines of LGBTQ+ health equity, working every day to balance compassion with advocacy. Our next step is to turn their experiences and stories into stronger policies, more sustainable funding, and education that supports both patients and providers. Thank you for your attention today. And with that, I want to transition to the next session on workforce resilience and coalition action with Ben. And please, to view the report, you can scan the QR code, you can see the link. I'm sure Jared will include it in a follow-up email as well. So thank you all for listening to me talk about data for a bit today from our report. So thank you, and we'll move over to Ben.
Thank you so much again, Sarah, Scott, and Jared, for bringing us all together today. This has been, and of course, Jackson as well. This has been a very important series of presentations, and I hope I'll do all of your work so far justice by concluding it effectively. To conclude today and tie all that we've been doing here today together, I wanted to highlight a few notable statistics from our survey. For nurses' patients, for the most significant barriers to LGBTQ plus patients accessing services, respondents listed 4 factors. First, stigma and discrimination. Second, distrust in the health system. Third, trust or insurance issues. And fourth, distrust in the federal government. For nurses themselves, for the most substantial barriers to providing services to LGBTQ plus patients, respondents listed in order: lack of provider training, lack of insurance coverage, and lack of federal funding. All of these barriers, and we've heard the previous presenters talk about them extensively, constitute the unfortunate reality of the work that nurses and every single healthcare provider today do. Substantively addressing these barriers is therefore crucial to materially improving how our healthcare system treats LGBTQ plus patients who pass through and interact with it. This survey suggests an LGBTQ healthcare policy environment that's highly restrictive on the federal level and is highly vulnerable to acute external funding shocks, and that unfortunately often underserves the very same LGBTQ plus patients that the system should be properly and fully serving. This environment also indicates the need for sustained and substantive advocacy for LGBTQ plus patients, particularly on the state level, where material protections can and should be implemented. Speaking of protections on the state level, gender-affirming care shield laws, such as California's own, while an imperfect solution to a complicated and clearly ongoing, again, as the previous presentation showed, problem, are crucial and needed to protect as much as possible access to gender-affirming care. Moving forward, throughout the country, there's a real need to build health systems that properly operationalize LGBTQ+ patient-centered approaches, cultural competency and provider pipeline considerations, and inter and intra-system routinization of care best practices and integration. In this time of acute tumult, disruption, and change to our health systems, we can and must recognize and address the particular healthcare disruptions and inequities faced by LGBTQ+ individuals. With their key position within health systems, nurses are very well positioned to play a crucial role in this broader effort. And here, to conclude, I would like to situate us within history. We are currently, clearly, living in a time of backlash. Just as we've seen in the past with LGBTQ+ rights in health, progress, the increase in de jure rights, de facto acceptance, and access to affirming and non-judgmental healthcare is not inevitable. The next stage of LGBTQ+ history and of LGBTQ+ health is being written right now. And we, everyone on this webinar, are all the authors of that history. And I want to leave you all with that message today as we move forward to the next slide. Moving to additional educational opportunities that are offered by the coalition, building on a lot of the topics that we discussed before, I wanted to highlight here our coalition's National Training Center, which is available at the link indicated on the slide. This training center has expert-led live training opportunities, on-demand CE, CME, CNE, and CPE certified education, and practice aids for clinicians and support service providers. And that, again, that LGBTQ National Training Center is available at healthlgbtq.org/theq. And a lot of the topics we talked about today, there's a variety of ways that we address them on that National Training Center as linked here. Further, we have a multi-module series on here. I won't go through all the different names of these modules here, but again, very much along the lines of what we discussed previously in the presentation today. The coalition also has a MFAX campaign regarding MPOX education awareness, which is available at mpfax.org. This is part of our work on other infectious disease states, and you can see an example of one of our graphics from that campaign on the right side of the screen here. Further, the coalition also has more up-to-date MPOX resources, which are available at healthlgbtq.org/MPOX on our MPOX Resource Center. The MPOX Resource Center provides the latest information on virus transmission, prevention, testing, and treatment. You can also visit cdc.gov/MPOX for more information. Further, we are participatory in Let's Stop HIV Together, or the Together campaign, which is a national campaign to support the CDC's Ending the HIV Epidemic initiative. This campaign's purpose is to increase knowledge around HIV prevention, testing, treatment, and stigma. You can visit cdc.gov/stopHIVtogether for free resources to share on social media and at your organization. Finally, the Coalition, as well as Health HIV and Health HCV, hosts a national conference regarding LGBTQ health, HIV, HCV, STIs, harm reduction, and, crucially, again for this presentation, health equity, called Synchronicity. Sync 2026 will be held from March 18th to 20th, 2026 in Washington, D.C. Syncconference.org is the website, and you'll see that here again on the slide for the conference as well. Further, if you would wish to submit an abstract for the conference, and we are still accepting them through November, you may do so via the QR code on the right side of the screen. I'm just going to pause for a second in case anyone wishes to scan that right now. And again, more information about this is at the syncconference.org website as well. All right. Well, we do have some time for Q&A, I believe, but just to briefly highlight here, we also have additional contact information if anyone should like to contact us, or if you have any additional questions or like to follow up on any additional matters as well on this slide. Thank you again so much for having us here today. It was a real pleasure to work with all these lovely people here, and we wish you the best in your fight for health equity and LGBTQ plus health equity in particular. Thank you, everyone.
Thank you to the entire team here at the National Coalition for LGBTQ Health. As I sit here and think about all the advocacy work that goes into produce a body of work like this to cover as many facets and areas of opportunities, barriers, challenges, in as succinct way as you all put it in less than 46 minutes, really puts hope back into some of our daily lives. And I think it can be so demoralizing sometimes as we tune into our social media feeds, news feeds, and feel like you may be the only one that is out there and trying to advocate. But clearly, this is a great and amazing body of work, so much information in here. So thank you so much. We did have a couple of questions in the chat, and hopefully there's a couple more that we may be able to get to that I have on my list here as well. To hit off the top of the bat and give you a nice hard ball right up front. And thank you to some of our association partners who have been joining in the chat. There's questions around those who are in Republican-led or supermajority states and wondering how either their associations, those individuals or advocates may be able to help hold legislators accountable, especially as it violates some of those code of ethics and moral principles that we all have.
I would quickly jump in around an advocacy component. We work a lot around formulary restrictions, which matter, primarily for for anyone who is on HIV medications or comorbidity medications or, the issues that we have. And I think one way that you can actively get involved in states that have some of those supermajorities is make sure that you connect with whether or not your state has what's called a prescription drug affordability board to help shape some of the qualitative and quantitative conversations about what patient outcomes and experiences mean. But another way is every state has a Medicaid Providers and Therapeutics Committee that too also shapes how formularies and treatments and guidelines shape the work that is being done. So I would say there are two immediate ones. And then also right now there is a consideration for the Older Americans Act, or the OAA, that is up for reauthorization. And having comments that are put in because, we're proud that 7.6% of the population identifies as LGBTQ, and we're all aging, So as we work within the OAA, there are mental health and behavioral health and supports that are fundamental to the OAA that I think getting involved in and making sure that there are considerations for aging populations within LGBTQ considerations have that. So I think those are three easy ways. Obviously, there's other ways around AIDS drug assistance program conversations, but a lot around targeted case management and some of the other things that we had mentioned. But I'll stop the floor here. That's a hard question, but it's a fundamental one.
It is great. And, there was, as Scott or Benjamin, there was a few asking if some of those early names could be repeated, some of those areas of opportunity to reach out to, like the prescription drugs, et cetera. A couple of chat. Next question here, as some of the data, web pages, portals are being taken down, information is being changed. Where do you suggest that nurses and healthcare professionals go for accurate, up-to-date information?
I think a lot of nonprofits like ours and organizations and um, folks that are obviously seeing that decline in data have taken it upon themselves to archive a lot of materials. And so I would research your local nonprofits or national nonprofits for the subject that you're looking for, and their data is going to be comprehensive of a lot of the federal data that you're seeing out there. And oftentimes they'll use those in their resource pages, or be able to save them in a way that makes access to that information still available. So I would definitely start there. I know there are a few groups that have taken to at least archive some of the CDC resources, and that's going to continue to happen. But organizations like ours, continue to utilize those archived resources in our work, and then we'll always provide, a downloadable copy because that's what we're using as well, and typically use that on our resource pages. So I think it's a good place to start, and uplifting those nonprofits so that they can continue to do that work is integral in a time where we're losing a lot of that federal data.
Absolutely. Thank you
Yeah.
so much, Sarah, for that response. I just have two more quick, maybe not so quick. This is the next one. There was a lot of discussion around behavioral health, depression, anxiety, substance abuse in the restriction or tightening of access to care, especially for those issues. So safety nets become to be that key phrase that may be thrown around of where, if I can't go here, where else can I access care? Could you offer up some suggestions or opportunities, especially as we have our nursing and healthcare providers here who may be looking to assist those that they come in contact with?
Shape that question slightly different. Like where can people go to turn to, right? Is what I mean, obviously from the practice transformation standpoint, clearly you can look to, the best practices models that we have within the National LGBTQ Health within the Q Center, which has lots of those considerations for what best practices are. But it also filters down to just some of the basic conversations around like utilization management. What does that mean as far as your insurance goes? So the step to get into the door of healthcare, I think, is absolutely important. Staying engaged in that healthcare also is every bit as fundamental, and trying to see what those best practices are, or how your insurance plans or how your Medicare or Medicaid or other can actually help uplift you, and help support you, I think, are other ways. So I would certainly say please look to our Q Center and to the coalition for some of those best practices activities. And obviously, the American Nurses Association in California has an entire practice continuum of those issues. So I would definitely say circle back.
Appreciate it.
Yeah.
Thank you, Steve.
In addition to that, Scott, just to add on a little bit, further than the queue, which I definitely do suggest as an initial stop by for resources, HSS also has a very good compendium about caring for LGBTQ clients in a hospital setting in particular. So that's can be a good resource. In addition, there's a lot of good resources from Emory University as well. They have a great compendium of resources on LGBTQ plus cultural competency that we've utilized in the past. So just to highlight a few additional points too.
Thank you both. Yeah, very helpful. Then the final question here, we have some colleagues from the Kentucky Nurses Association. Thank you for joining. And they're asking, I think, a very important question. A, how can their organization, their practice group that is focusing on this particular issue get involved with the coalition or become members? And I would say extend that question along to individuals and other organizations, nonprofits who may be interested in getting involved with the work that you're doing as well. Is there a quick location place where they can get signed up? I know you dropped the membership link in there before, but subscriptions or something else to start that involvement.
Yeah, absolutely. Well, definitely signing up via the link that Sarah had, I believe, put in there is very helpful to be able to be added as a coalition partner. In addition, I'll put the link to this in the Q&A as well. We don't have it yet. But we also have a link to sign up for a mailing list too, as well as our parent organization, Health HIV. So you're welcome to get any emails you want from those subsections.
Terrific. Well, thank you. Oh, Scott,
Oh,
please.
I was simply going to say, as I was saying Kentucky, we had worked with the Kentucky Health Department not too long ago around carceral individuals, right? So as part of this conversation too, is a whole continuum of conversations that need to happen within health services clinics and jail services, right? That needs to replicate that, because simply because you may be behind those closed doors, it doesn't mean that the door should be closed for you for your health. So I'm so glad to see that Kentucky was on there.
Yeah, amazing. You know what? Something that is beautiful to see is how many people have been in the chat sharing where they're from, what they're up to, but also how many people have been sharing their personal contact information. And it really talks about a community, and that is needed to have the impact and changes that we all would hope and like to see. So thank you all for participating today, and thank you again to the National Coalition for LGBTQ Health. What an amazing presentation, and look forward to some of the next steps that we have in the works as I twiddle my fingers together maniacally, if I may be. Moving on to the next portion, I am so excited and thankful to have two of our fellows here that have been working on ANA California's LGBTQIA plus equity in nursing campaign. This is really an embodiment of work as I share my screen. Um, sorry, wrong button there. Uh, I'm very thankful, and this has been such a great lead into sort of the reason why Andy California has been on this road and have this campaign. Touching upon many of the data points, you'll find some commonalities in what we have been able to see through our assessment coming up. Bree is going to help cover our process, very important to showcase for the nurses and healthcare providers here, how we are setting up the campaign and how we're proceeding forward with the work. And then our fellow Misty will be sharing some insights into our LGBTQ plus equity in nursing assessment that is currently in the engagement cycle and will continue through March of next year. So without further ado, I'd like to pass this off to Bree. Bree, I've got control of the slides, so you just give me the heads up.
Thank you, Jared. And what an amazing presentation that preceded this one. So thank you for sharing all of that information. And it during such turbulent times in our country and in our profession, I am hopeful that there's so many individuals on this call that are feeling empowered to be actionable on how we can make sure we ensure equity for everyone, including our LGBTQIA plus patients and providers. So my name is Bree Dubose. I'm a registered nurse, proud ANA California member, and 2024 Advocacy Institute fellow. Just to give you a little bit of overview of our timeline for this LGBTQIA plus equity in nursing. The fellowship was approved in October of 2023 when I was approached and selected to be the LGBTQIA plus advocacy fellow for 2024. During that 4-month period between October and January, and I'll talk a little bit about this before, I was able to coordinate with Jared on building our task force, which then convened in January of 2024. We spent the next 11 months meeting as a task force to be very thoughtful and deliberate on the creation of our assessment. And then we're very proudly able to launch that assessment in July of 2025. It's now October of 2025, and the work is still continuing. That assessment will be available through the early 2026. So we'll be sharing some links on how you can participate at the end of this presentation. So I will be discussing, I shared with Jared and Misty, I am a concrete sequential thinker. So I'm going to use borrow Donna Bedian's model for structure, process, outcome, just to share on our task force approach. So I'll be sharing the structure, so how we created the task force, the process of creating the assessment, and then I'll turn it over to Misty, the 2025 Advocacy Institute Fellow, to talk about some of our early outcomes from the assessment. So building the task force, we started by identifying LGBTQIA+ leaders across the state of California and beyond. We really saw a critical success factor to make sure we had a diverse group of individuals that had various levels of roles and experience within healthcare. So that way our assessment would be reflective of what is accurate and actionable for the nursing profession. We had engagement meetings with myself and with Jared, with each of these prospective task force members. And we really wanted to assess that they had the passion, the expertise, and most importantly, the bandwidth to participate. The creation of this assessment for these task force members, which I'll highlight in a few slides, was really a labor of love for them and their dedication to improving equity in the nursing profession and beyond, because it was a heavy lift for them to meet with us so frequently. And we wanted to make sure that those individuals that participated had the bandwidth to participate, so we can make sure we maintain our diversity of the group throughout the entire assessment creation period. We convened in that right at the end. Our goal was January, so we just made it on January 31st, 2024. We had our first task force meeting, and we established our mission, our goals, and our timeline, which I'll talk about on the next few slides. So our mission statement is to cultivate a nursing workforce that embodies the principles of diversity, equity, inclusion, and belonging, where individuals with varying sexual orientations, gender identities, or expressions are actively embraced and respected. We strive to create an environment that fosters a sense of belonging, understanding, and acceptance for all members of the LGBTQIA+ community and beyond within the nursing profession. You can't improve what we can't measure. And there was really not a lot of other information across the United States and beyond that did an assessment on what is the equity and lived experience of our nursing profession as it relates to LGBTQIA+. So very proud of this assessment that's able to help close some of those gaps. Our goals was to create an assessment specific to LGBTQIA+ equity within the nursing workforce and profession. So as I stated, there are some other assessments. We heard some of that other great work that's happening, capturing some healthcare experience and then the patient experience, but we wanted an assessment that was really specific to the nursing workforce and our profession. And then the goal is to be able to conduct a case study to utilize the assessment to generate statistically significant data so we can have some actionable responses. Again, this was the work of many individuals. We were very fortunate to have engagement among a wide variety of nursing leaders, bedside clinicians, nurse practitioners, advocates that were able to participate in building this assessment. So that way it was really built off of their knowledge and their expertise. We also had some very talented contributors that were able to join us, including our own ANA California CEO, some representation from the East Coast, a CNO, and 2 nursing students who, when they joined this task force, were nursing students, and now they are registered nurses. And then, of course, none of it would be possible without ANA California's support, and particularly the very talented and very tall Jared. So our process for creating the assessment, I really wanted to build a structured approach for our bi-monthly or bi-weekly, so every other week meetings. The expectation was that our key task force members would attend as many meetings as possible. But if for some reason they weren't able to, we wanted to make sure the work that was happening was transparent and accessible for all. So we had a structured approach for our bi-monthly meetings. I'm a big believer in the most that you can make known and expected up front. It frees up mental bandwidth to be able to think about things creatively. So every meeting we took attendance. We started with a reflection to set the tone for what we would be discussing. We had role assignments, particularly a process checker. We have such passion on there that sometimes we would want to talk about a topic that's maybe not exactly related to the assessment. So making sure we had a process checker and a facilitator, which was often myself. And then we would review any agenda items and our next steps. Another critical success factor for creating this assessment in a short 11-month is that we had a working document that was a shared document that was accessible to everyone. So that way we had transparency of the work in flight. So if a member was not able to come to attend a meeting, they could always go and review what was happening and be able to provide their feedback. So that way we always ensured we had diversity in the inputs for the assessment. We built off of the racism and nursing assessment as scaffolding, and then augmented that with literature reviews and subject matter expertise input. In each meeting, we discussed and refined what should be the assessment questions, what should be added, how they should be phrased to make sure that we're asking the question in the right way to be able to get the information that is meaningful and actionable. How can we build in branching in the questions to lessen the administrative burden of taking a survey, even though we didn't want to create a survey that was too challenging or too long to complete. So how can we organize it with branching to make it easy, and then make sure that we stayed within the scope of the assessment? What happens in the community and patient care is very important and very valued. But for the purpose of this assessment, we really wanted to focus on the organizational status and the nursing profession lived experience. So these were the final assessment components. There are 10 categories. First, we wanted to understand our respondents with demographic questions. Then we wanted to assess their understanding of definitions, so their knowledge level of certain terms that relate to LGBTQIA+ equity. Understand and the ability to identify microaggressions. Capture what's the culture of the organization on having these conversations. So, there are many organizations that have policies in place, but what's the culture that happens beyond those policies? What's the reporting comfort? So if a nurse witnesses or is a victim to anti-LGBTQIA+ behaviors, how comfortable are they and are their peers in reporting it? What are the DEIB training, both mandatory and optional, being offered by the organization? On the organizational DEIB, do they address inequality and inequity? Our hiring succession planning. So is the organization attractive to LGBTQ workers, and are there equitable hiring practices? And does the staff diversity match the patient population being served? And then finally, just the belief on the organization, on the respondents' perception of the organization, on whether it is anti-neutral or pro-LGBTQI+. I'm going to turn it over to Misty now to talk about some of the early outcomes from the assessment.
Thank you so much. So one of the things that we had a challenge with initially was around institutional hesitancy. We did try to partner with a number of organizations, very much like our racism in nursing campaign done previously. As Scott mentioned, there's been a huge shift in the support of LGBTQ, particularly relating to challenges of funding. Many organizations that we reached out to voiced hesitation about participating, specifically in this equity assessment, due to concerns about visibility, particularly amid politically charged discussions about LGBTQIA plus care. Leadership cited a number of fears from external criticism, political backlash, and funding implications. Again, without funding, they're unable to continue to provide care to patients in the community. So these are real and reasonable concerns. With that, many institutions, as we're talking to them, still are working very hard to provide appropriate care to the LGBTQIA plus community. With all of these fears, it really does underscore a broader truth that advancing equity really does require courage and clarity. As healthcare providers, framing LGBTQIA inclusion as an evidence-based standard of care and not a political stance is essential. When institutions lean into this kind of work, they do demonstrate leadership, accountability, and alignment, but we also need to have an understanding of what's at stake as they highlight the work that they do for this community. Next slide. So in regards to the respondents that we received, we had 624 individuals complete the survey. The survey went live in July of 2025, representing a diverse range of nursing professionals. Respondents were in multiple roles, and all of the assessments collected were anonymized, collectivized, and excluded either incomplete or corrupt data. In regards to respondents, a vast majority of our respondents were from California, so we did have an 85% response rate there. 12.2 of the participants did not report a location, and we had 2 to 3% responding in from other states. Just to give you a more full vision as far as who was included in those responses, 87% of them were non-exempt roles, so oftentimes bedside nurses. 13% were in exempt positions. Another thing that I want to mention is as we're looking at the data overall, while we had 624 participants, 59% of those responses did come from a large Bay Area health system. It was a health system that was able to help support the campaign. We did have 41% of responses from other institution. This does highlight some of the challenges that we have had and also the need to expand out this assessment. So as Bree mentioned previously, this assessment is still open and we are really looking to add additional voices to this assessment as well. Go back, sorry. The mix does, however, offer both depth and breadth but again, does highlight that need for additional voices and will provide an opportunity for you to add to this data at the end of the presentation. Next. So one of the first sections that was accompanied in this assessment, respondents were asked to self-assess their understanding of foundational terms such as gender diverse, microaggressions, and marginalized. There were 4 available responses that you can see on your screen that range from "I don't know what it means" to "I can demonstrate and teach to others." Next. The data clearly showed knowledge gaps. Terms like gender diverse and microaggressions had the highest number of respondents indicating unfamiliarity. This suggests that while awareness of diversity topics is growing, conceptual understanding and application really do remain limited. It highlights an opportunity for us to engage in deeper levels of education beyond just introductory DEI training. Next. The next section of our assessment really looked at microaggressions. Again, microaggressions in general was a term that some of our respondents did struggle understanding. However, when we looked at various statements, when our participants looked at various statements in regards to that could be perceived as microaggressions, um, common examples included such as "it's a choice," intrusive questions like "have you had the surgery?" and also heteronormative assumptions such as "who's the man or woman in a relationship?" These findings emphasize while there is an awareness of bias, inclusive communication remains a developmental lead. Um, as you can see, in regards to these statements here, only 35% of those that responded noted that your gender or sexual orientation is a choice. And that's really important to know. Statements such as "I'm not biased, I have a lot of gay friends" was not considered overall as a microaggression. Only 26% of respondents noted that as a microaggression. So again, the findings really does emphasize that while there's an awareness of bias, inclusive communication remains a developmental need. Addressing microaggressions requires really ongoing education, leadership modeling, and a culture that prioritizes respectful dialogue. Next. So these were a couple of themes that we looked at in regards to microaggressions, invalidating themes. So really identifying the LGBTQ plus identity with statements such as "it's a choice," intrusive personal questions such as "have you had the surgery?" Heteronormative assumptions, and then also just really an indication of awareness of bias, again, underscoring the ongoing need for inclusive language and sensitivity training. So these were really areas that we continue to evaluate through the assessment. Participants were asked about their comfort level discussing LGBTQIA plus inequity and equity issues within the workplace. Many respondents expressed openness, but indicated that these discussions often depend on leadership example and team culture. Where leaders created psychologically safe environments and normalize inclusive dialogue, staff were more likely to participate in these conversations. Conversely, where there was silence or where there was avoidance that persisted, opportunities for growth and understanding were lost. So this really reinforces the pivotal role of leadership's visibility in shaping inclusion. Next. So there was a number of barriers noted for these conversations. One was religious-based barriers at 18.4%. Religious affiliated health systems often, participants noted that they often had a limit or they avoided LGBTQIA or gender equity discussions. So they really didn't feel comfortable in that environment. Staff also reported that inclusivity, when actually present, is often superficial, inconsistent, or contraindicated or con, con ah, words today, uh, contradicted by institutional policies. The other piece of it, 13.2% as far as challenges, had to do with federal or VA related barriers. So that included multiple comments that cite that the VA and federal institutions noting the dismantling or rolling back of LGBTQIA policies and DEI initiatives. Uh, Staff members also noted within this category reduced psychological safety and then also losses of services for both transgender and non-binary veterans. A couple of other areas that I just want to tack on is a note around conservative climates. Local population or culture and conservative staff attitudes also contribute to resistance. Some staff members also openly express political or anti-transgender sentiments in a professional setting. There was also challenges around education. So many commented that there was limited training, poor knowledge, or discomfort around LGBTQIA topics. While they did mention that pronoun sticker use is increasing, it is also very inconsistent. Some staff members noted that colleagues were often dismissive or resistant. A couple of other areas, again, involved kind of performative inclusion. So 13.2% noted performative inclusion as a challenge, really kind of gauging back to the fact that organizations may provide some small tokens of support, again, pride stickers, badge reels, but had challenges around embedding inclusivity in both practice and culture. Often the training, when there is training provided, um, are seen really as checkbox exercises rather than cultural shifts. Next. So we did talk briefly about the importance of reporting for LGBTQ equity. In the area of reporting comfort, 66% of respondents said they have clear and accessible steps to report issues. 63% confirmed mechanisms exist to do so, and 71% felt comfortable reporting anonymously. About 70% indicated confidence in their organization's escalation pathways. While these numbers do reflect progress, the data also reveals that nearly a third of respondents remain uncertain or hesitant, pointing to a need for improved transparency and reassurance that concerns will be addressed without fear of retaliation. So adding in regards to DEIB training, survey themes on training frequency and impact showed a wide variability across organizations. Many participants reported having completed some form of DEIB training, but fewer described meaningful or sustained changes in skills and attitudes. In short, Knowledge increased, but confidence in application really lagged behind. This finding really reinforces that inclusivity training should not be treated as a one-time requirement, but ongoing. To shift culture, DEIB content must be embedded throughout professional development, through leadership pathways, and also through performance expectations. Next. A note in regards to organizational DEIB. 70% of respondents reported that their organization provides a mechanism for staff to make recommendations to executive leadership on LGBTQIA plus equity. With that said, only 30% were aware of a dedicated DEIB representative or a team or any kind of specific focus on LGBTQIA. 62% stated that they did not know whether such a role existed. This lack of visibility really underscores a critical communication gap. DEIB efforts must not only be present, but well publicized, accessible, and integrated into organizational structures to be functional. A couple of notes in regards to hiring and succession planning. When reviewing recruitment and hiring practices, only 21% of organizations reported using standardized interview questions to minimize bias. And this is really noted as a best practice in the literature. 17% use diverse hiring panels, only 10% include inclusive job descriptions, and just 5% conduct targeted outreach to underrepresented groups. Furthermore, when asked if workforce demographics match the populations served, next, only 17% said leadership reflected the diversity of the community that they served. While there was a note of 69% congruence in regards to staff level positions, we have a long way to go for leadership to match the population that they're serving. So these results really reveal a need and an opportunity for organizations to embed inclusivity directly into their hiring, advancement, and succession strategies.
Apologies, this image appears to be corrupted. Christy, could you proceed
Yep.
with your notes? Thanks.
Okay, perfect. So we talked a little bit about, we looked at the perception of organizations. So looking at the perception of staff members about their organization, it really, respondents were asked to assess how their organizations reflect and support LGBTQIA staff and patients. The responses really showed significant variability, but a clear theme really emerged. So many professionals felt that inclusivity efforts exist in name, but are inconsistently experienced. Authentic inclusion requires moving beyond some symbolic gestures towards policy and practices that affirm every individual in both care and employment environments. Now that the chart is up, while there is, again, a large number of strongly pro LGBTQIA, in practice, there's a lot of gaps per reporting of nurse staff members. So with all of that said, right, where do we go from here? So again, preliminary data but there's definitely some things that can be gleaned. One is around utilizing hiring strategies for LGBTQIA plus equity, informing staff about LGBTQIA resources and DEI resources, and expanding practical training and visibility of inclusive programs. We can have LGBTQIA resources and programs, but without the visibility of leadership promoting those programs, um, we're not getting their benefit. We do need to look at embedding inclusivity into performance onboarding and leadership development, again, to weave this throughout organizations. So a couple of bright spots that I do want to mention, we are finding that new leadership is driving inclusivity and opening dialogue. There is definitely an increase of growing interest in LGBTQ education. There's increased visibility of inclusive signage and pronoun awareness. And cultural excellence initiatives have been emerging across multiple organizations. But for us to continue these positive changes, we need to continue to advocate for them within our healthy workplaces. So to end, I just really wanted to say that, this initial benchmarking is in preliminary state, and we really want to encourage everyone that is in a nursing position to share your voices with us as we complete this assessment. Sustained leadership, education, and transparency is essential, and together we can advance LGBTQ plus health equity in nursing. So with that said, we're going to go ahead and open it to Q&A. I do want to mention that the survey for the National Coalition of LGBTQ Health is available through this QR code. And then additionally, we have the LGBTQIA Equity and Nursing Assessment. And just really want to hear your voices.
Thank you so much, Misty and Bree. And while I was sharing my screen, I wasn't able to hear to look at the chat, but I think some of these insights, it's amazing how synonymous some of the insights from the annual survey from the National Coalition for LGBTQ Health and some of the insights that we're beginning to see through our assessment, especially around the educational component. There seems to be a big gap, right? We talk about this fairly often in nursing, and I wonder how it may extend beyond to other healthcare professions. But sometimes the checkboxing, right, gets us only so far, and I think that's what we're seeing in a lot of perhaps different capacities, and that may be for various limitations. It may be institutional limitations, leadership limitations, individual limitations, but regardless, moving beyond some of the baseline foundation and educational steps and moving towards what may be implemented within the practice, within the policies and procedures that we have to ensure that the level of care that we'd like to deliver, that we are beholden to through our code of ethics, right, can actually be actualize in those conversations, in the care management, in the delivery of care. So I know that there's some other similarities here, but as I take a moment to look through the chat and see if there are any questions, perhaps if there's any remarks or comments, either from Missy and Bree or the National Coalition team on what we've shared here today.
I just want to underscore the importance of these collaborative conversations where we can bring in, folks such as the National Coalition for LGBTQ Health and ANA California to have more synergy in the work that we are doing to advance LGBTQ health for our patients and also for our providers, because a healthy, equitable workforce can help drive healthy, equitable communities and patients.
Yeah, Jared, you mentioned it, and Bree, I know Misty, you and Bree both spoke about training being so integral to a better, stronger, more affirming workforce, and talking about those one-time trainings or access to training. And, we hear a lot, and I'm sure you did too, and you said about your data that just making time for professional development is not feasible for so many folks. And a lot of organizations and establishments are reducing the amount of time they'll even pay people to interact with professional development. And so, again, that underscores why our relationship is so important, because we can provide that data and those resources, and they can be then on demand, right? Like, there doesn't have to be such a focus on in person or trainings that have to happen at certain times and places, and being able to be adaptive in that education is incredibly important. And we've seen a lot of that change over the last couple of years, especially with, the focus on the pandemic with remote care. And I hope that we can continue to provide those resources to individuals where it can meet them best. And I know both of our organizations, hold that to a high level of importance, and being able to provide those resources.
And just to echo some of Sarah's comments as well, I think what you all have done here is incredibly impressive and part of the crucial work that we really have to all do across every single state to ensure that we're embedding LGBTQ plus cultural competency, training, all of the above into every single profession. Every profession obviously has their own considerations. Every state has their own considerations. And I think your work is a clear step forward in California for nurses in establishing some of these principles and routinizing a lot of these very positive care practices.
It seems and happens often in policy campaigns that a lot of this comes down to the passion, at least within the institutional perspective, passion of leadership to move forward things that are personal or beholden to their values, morals, principles. But when that passion or that leadership is missing, creates gaps and holes in what the trajectory of the staff and what they are able to access or educate themselves on. Is there, from your all perspectives, and I'm not a nurse right here or an expert on this topic, so I'd love to hear what steps would it take to begin to standardize some of the policies and approaches that institutions can have, so we can have a more systemic response, if you will, to ensuring the appropriate care, not only for the patients, but then for those nurses and healthcare professionals who identify with these communities.
Think one of the challenges too, I think the importance of sharing the practices that you have. So the ability for organizations to have the courage to say, you know what, this is what we're doing, because there's a lot of organizations that are out there that are doing the work, that are creating these best practices. Again, there's hesitancy to share some of that because of the current climate, but really collaboration, and communication is really needed.
And I really like the way, Jared, you put it, is that oftentimes organizational training and development is based on certain things that hit home to leadership, right? But then that creates churn and turnover potentially every single time a new leader is in place, and then that resets the priorities, right? So then now you have a workforce that is constantly working in fragments of, this is a priority to my leadership, so this is all of the training I'm getting, or on this topic, and now it's changing again. And we have to hold our leadership accountable, right? We have to work together and talk to each other, and because the best thing to do to be able to get that message across is form a unified message, right? Talk to your supervisors and managers that can then inform leadership, that, it's tough to be refocusing and changing priorities, every single time we get a new leadership in the house, and talk about what is actually impacting our patients. What are trainings that can actually work with the function that we're providing and the patient focus, and using surveys like that you provided through nurses and getting the data directly from the people offering the care is hopefully going to help inform and provide a basis for that conversation to help leadership understand what is needed to help move the needle in healthcare.
Well,
I think oh, go ahead, Jared.
Well, I was going to say there's a lot of conversation around, the concern of being public or highlighted or spotlighted doing this work, but there are those institutions who are very dedicated and passionate about addressing these issues. From the coalition's perspective, what does the communication or messaging or relationship look like with your coalition partners, and how do we keep everyone on these best practices to ensure everyone can move forward with some similar success, we may call it?
Yeah, I would step in real quick. We're not a dues paying membership coalition, right? So our annual activities is the third annual, or third full week of March, the Health Awareness Week. So that is a huge activity. So I think there's a great opportunity within that week to highlight some of these conversations and to make sure that they're then backed up in some of the implementation science that we have and the best practices. So I would say there's one opportunity there as well. If others would like to.
And I think one thing we've very successfully done is engaging our membership, everyone who signed up with as a partner with us, very effectively on some discrete topics as well. One example of that has been our MPOX education and microgranting program, which we're hoping to launch again very soon, hopefully. But we've been very successfully able to work on that to advocate for best practices on education related to MPOX and organizations throughout the country. We've been able to disseminate our campaign throughout the country. So I just think utilizing our reach as an organization through our partners, communicating with them about the topics that they care about, and harnessing resources and the issues of the day and the issues that will continue to be the issues of the day for the foreseeable future has been something we've been able to do.
Looking at the time here, I think one final question. It is incredible to have such uh, educational information. I mean, the breadth is here. Scott detailing a lot of the federal and state challenges and barriers, and then Sarah Jackson being to detail the insights and data that is from the survey. And Bree and Missy, thank you so much for doing the same from our perspective. Again, educational is terrific. What are, as sort of a takeaway or leave action items for nurses and healthcare professionals that are tuning in today? Something that could be tangible for them when they show up to work later today or tomorrow, that may help them start their or assist in their own institutions campaign to ensure that we have appropriate access to care for these communities.
When I ran our medical case management programs in Washington State, Lifelong AIDS Alliance, we met with a lot of nurses on a regular basis as part of the clinical care practices, right? But we also talked about the social determinants of health. And I know there are so many multidisciplinary team practices, meetings that happen. And these are like a really tangible way to less to converge around the social workers and the nurses and the doctors having conversations about how to rectify or how to remediate, but to actually how to then proactively stave off these issues like microaggressions that may happen within clinics, within administration, that then could then have further conversations, with the leadership within those MDT. And those are often obviously it's as multi, Many organizations come in that are internal and external, and that voice carries through. So I think that's a great, easy way that we saw that we were able to effectuate change. And then it starts conversations about what capacity building and technical assistance is needed next, beyond just the conversation in that moment.
One other thing I just want to highlight, building on what Scott said, is the importance of recognizing the real power that you have, both for good and potentially for ill, as any kind of healthcare provider. You can make a huge difference in the lives of your patients by adopting a lot of these best practices that have been described throughout the presentations. And I think that's really something to take home here, is that you really do have a huge impact, both in terms of every patient you deal with and in terms of the organizational culture that you work to build. And that can be a really positive organizational culture, really positive impact, and relationship with your patients if that's something that you move forward and actively seek to do.
And to build off of Ben's comment on the power, as registered nurses, nursing is our profession. Where we work is our job. So I think it's important that when we are, applying to work within organizations or working there, that we continue to use our voice with our leadership and communicate that providing equitable care to the LGBTQ community and beyond is part of our code of ethics and our duty to a profession. We have a contractual relationship with the community to do so beyond the political landscape or the organization in which we work. So I think we need to continue to have these conversations with our leaders and say, we want to work in an organization that we're proud. I'm very fortunate that I currently do, that we're proud of the work that they do in the DEIB community. So I think see your power as a nurse and our collective power as nurses and healthcare professionals, and continue advocating even when times are scary. Now's not the time to back down on those conversations.
Couldn't agree more.
Nurses, oh, sorry. I was just going to say, nurses interact with so many patients that it's easy to lose a face in the crowd. But oftentimes for that patient, you are such a memorable part of their experience in healthcare and interaction. And it's hard to see that impact sometimes when you are managing a heavy caseload across a 12-hour shift, and a life outside of that, right? Just like Bree talked about, it's our job, but we also have a whole entire full life outside of the work that we're doing every day. But oftentimes you are a big experience for the folks in that room, and that you're somebody that can make a tangible change. A fun story that I was just with my father, my 75-year-old father, this weekend, and he has finally stopped biting his nails, and because the nurse told him to. He's married to a nurse, and his daughter works in healthcare, but for 75 years, he has bit his nails, and recently a nurse told him to stop and finally got through to him. So simple change like that, and I was blown away. But you don't know how far a simple comment or a conversation can take somebody's healthcare, even amongst people that have habits for 75 years. So nurses are incredible, and we support everything that they do and whatever we can do to offer more education and training and support and advocacy. I know the coalition is behind nurses everywhere.
I love that, Sarah. I always advocate that we are in the position, regardless of our organizational policies, to create moments of gender euphoria for our patients. So how can we, extend ourselves and create those special moments?
Well, a huge thanks goes to the coalition and to Bree and Misty. Thank you all for being here. I think the real kudos may go to the over 100 that are tuning in today. Thank you for being here and spending 2 hours with us on this particular topic. You are going to be those that are help carrying this message forward and having that collective action together. We all couldn't do our work without you and without your responses and engagement. So continue to be that strong ally and advocate. We have several more updates coming here soon, including a couple more things that we're working on with the coalition. So thank you again to everyone. A reminder that this was a CE provided event from ANA California for those nurses that are tuning in and who are living and residing in California. An evaluation form will be sent afterwards, as well as as we're packaging up many of the resources and links that were shared today for an upcoming newsletter. So please stay tuned, subscribe, get involved, and raise your voice. And most importantly, thank you for being here. Take care of yourselves.